Okay, so it is 9 o'clock, so why don't we get started? Welcome, Dr. Gilad. Thank you so much for taking the time to speak with us this morning. If you want, I can just give you a little brief introduction, and then the floor is yours for your presentation.
Great. Thank
So,
you.
Dr. Gilad is a neurosurgeon who was previously a lieutenant commander in the United States Navy, where she served as the staff physician in the Department of Neurosurgery at the Naval Medical Center. She participated in a combat traumatic brain injury program that helped treat wounded soldiers upon return from overseas deployment. Dr. Gilad is a member of numerous professional organizations and has published in a variety of scholarly journals, including the Journal of Neurosurgery, American Journal of Neuroradiology, the Spine Journal, and Journal of Vascular and Interventional Radiology. So welcome, Dr. Gilad.
Thank you so much. And thank you for having me. I'm going to go ahead and share my screen and go straight into it. Can you all see my screen?
Yes, we can.
Okay, perfectly. Perfect. What I'm going to speak about today is specifically talking about minimally invasive approaches to spine surgery, but not just minimally invasive approaches, but to talk about specifically motion sparing techniques, which has been kind of a passion of mine. Um, Secondary to my experience in the Navy, one of our goals is to, these are young, active people, and one of our goals is to get them back to active duty as quickly as possible and to keep them in that capacity for as long as possible. So I had the uh, pleasure and I'm so fortunate to have had the opportunity to treat combat soldiers, to treat pilots. And so our go-to operation was what can we do the least invasive and to maintain their motion to mimic the natural anatomy of the spine as much as possible. And this is as opposed to offering fusions for these patients, for this patient population. So take a look at this, for instance. This is a 76-year-old woman, but we see patients like this who are much younger. But this happens to be a 76-year-old woman with osteoporosis who presented with isolated left lower back pain radiating to her left thigh. So a radicular type of situation. She has back pain, but that's something that she can live with. And what you're looking at here is a standing x-ray of this patient with significant lumbar scoliotic curvature, specifically with the concavity to the left side. And those of you who are familiar with anatomy would know that when you have a scoliotic curvature like this with concavity to the left side, that's going to lead to a foraminal stenosis or pinching of the nerve as it's trying to exit the spine on that side. So this is her MRI scan. And what you're looking at here, once again, is the scoliotic curvature. But at these two spots right here, if I can just give you some orientation and anatomy, what you're looking at here is a side view with these are the vertebra of the spine, these squares. These are the discs in between. And off to the left hand side, you can see that this nerve is getting pinched in a significant way here. Just again, to give you orientation, these gray lines here are nerves, and the white is cerebrospinal fluid or spinal fluid that cushions the nerves. So there's complete lack of cushion in this area right here. This image right here are cross sections called axial images, and what you're looking at here, this is patient's right side, this is patient's left side. In the center is the spinal canal. You have these dots that represent the nerves in cross section, and the white is cerebrospinal fluid that cushions The nerves on the right side, you can see the nerve is exiting without any problem at all. There's plenty of space, but that's not the case on the left side. And this patient was completely symptomatic from the left side only. Now, historically, and even today, with going back to the standing X-ray here, one can make an argument to try to repair this entire scoliosis. And that's a major, major operation. It requires hardware, requires screws, rods, hospitalization, 6 month to a year recovery. That's a big deal. And then, this is not one and done surgery as well. There are potential downstream effects of deformity correction surgery and fusing so many levels of the spine. You have a woman with brittle bone osteoporosis, so there are potential hardware complications. But then there's also something called adjacent level disease, where you fuse a segment of the spine and months to years potentially later, you have problems above or below where you fuse the spine. And that's something we see quite commonly. Okay, so here's her MRI. So what we elected to do, and I'll go to this in a moment. What we elected to do, since her chief complaint was just strictly left thigh pain, was just to treat this pinched nerve. And we elected to do that endoscopically, which is just an incision that's just a little bigger than a needle puncture. And so this is the OR setup for an endoscopic case. This is the patient's head is over here, feet are here. I'm standing on the patient's left side. This is from my point of view. Here's the endoscope camera tower right here. Um, Fluoroscopy, as we insert the instruments through X-ray guidance. That's what you're looking at here, and the screen for the X-ray guidance. Okay, so here are our landmarks. This is an AP view X-ray of this patient. I do apologize. The imaging I showed you is this is another patient, but same case. I just didn't have the images saved from the case I showed you previously. So this is the same case though to demonstrate. So here is our target from the left-hand side where we want to enter the spine. We want to enter through the foramen because that's the area that's compressed. On a side view of an X-ray, your foramen look like these holes that we're seeing. And so we want to dock our camera at the inferior or lowest most portion of the foramen. And why is that? That's because our nerve is traveling at the uppermost portion of the foramen. So we want to avoid that so we don't irritate the nerve that we're trying to decompress. Okay, so we draw lines of our landmarks and we draw lines showing our targets and our landmarks, and where those two lines intersect is our entry point for our endoscopic foraminotomy or nerve root decompression. So what we do next is we insert our needle through that entry point that I just showed you. And the tip of the needle, there are landmarks for the tip of the needle that we need to pay attention to. And that's the following. On the AP or face on view, these structures right here that I'm outlining with my cursor, those are the pedicles of the vertebra. So when we go medial or centrally from this border of the pedicle, you're in the spinal canal and that's not a space you want to be in. So the tip of the needle has to be right up until the medial border of the pedicle, which is this structure right here. That's on the face-on view. And on the side view, you want, just as I showed earlier, you want the tip of the needle to be within the foramen, but the lower portion or the lower part of the foramen so you avoid that exiting nerve root. Okay, so once you have your needle placed exactly where you want to be, the rest of the case just follows naturally afterwards. So you place a guide wire in, and then the majority of the case is going to be accomplished with this instrument right here, which is a trephine. And when you place that, it has a cutting edge to it as you rotate it. And when you're rotating it, if you could imagine yourself standing within the foramen of the spine, you're looking at the superior articular process of the facet joint below, and that is usually a contributing factor to foraminal stenosis or pinched nerve at the foramen level. So when you're twisting this instrument and cutting away at bone, you're actually cutting away at that superior articulating process and you're creating more space by doing so. So once you've finished your trephining, um, you've already created more space. You've accomplished about half of the foraminotomy just by doing that. You dock your sheath for your endoscope right in the foramen as demonstrated here on this image. And that's what the sheath for the endoscope looks like. And I placed my fingers here just to demonstrate how small the incision is. It's really just millimeters in diameter, a few millimeters in diameter, the size of a finger, and that's it. So that's where the endoscope goes in. So I'm going to switch my screens right now. Oh, and I'm just going to end the show here and actually show you video of the endoscopic portion. I'm so sorry, I shouldn't have that up. Um, okay, so let me pull up the video portion. These videos are too big to incorporate into the slide itself. So can you guys see that? I just want to verify that that's still showing. Can you see the video of the endoscopic portion?
Yes, we can.
Okay, great, great. Just want to make sure. So what you're seeing here, this top part right here, is the sheath for the endoscope that I showed. This is disc material, which kind of gets kicked up as we place the instruments in there. And what I'm doing here, and obviously the camera is in that sheath, we clean out some of the disk space. And what I'm doing is rotating that sheath so such that the bevel is facing south or inferior caudally. And the landmarks that we see here on this side of the screen, this is bone right here. So we're looking at the pedicle below. So this is L23. We're looking at the pedicle of 3 right here on this side of the screen. And then I rotate it further and our landmarks are the following. Up here is the superior articulating process that we actually shaved away with the trephine. So this is disc material here. This is superior articulating process that's been trephined and just buzzing the bone edges there. Pedicle on this side of the screen, okay? And our nerve root is on the other side of the sheath, superiorly protected by the sheath. So what do we need to accomplish here? I'm using this instrument that you see here. I'm using that to feel into the canal to as a nerve hook to make sure that I'm happy with the decompression, that we've accomplished what we intended to do. But I do notice that when feeling with the nerve hook, I notice that there is some compression still there. So what I'm going to do next is shave away more this superior articulating process with a drill until we see some epidural fat, which indicates to us that we have approached the lateral aspect of the canal and feel with the nerve hook, make sure we're happy with our decompression. So, this is the drill that fits through a port of the endoscope. It's a diamond round burr, and so it accomplishes hemostasis or control of bleeding as you drill away the bone edges. And one thing we like to refer to this process that's happening right here is we create a snowstorm. So everything gets kicked up on your screen. That's a good thing. You know you're making progress, and we refer to it as a snowstorm. But as such, we have to. One of the time-consuming aspects of this case is that often have to stop and reassess the situation because it's very difficult to see as you're making progress. But you can see here that we started making a dent in the superior articulating process. And so I'm going to fast forward now. A lot of the same. I'm going to fast forward towards the end. Okay. So you see that we're making that hole bigger. Go further. Okay. And now you start to see in this corner, you're starting to see some epidural fat here and indicating to us that we are really approaching the canal. You're starting even out here to see more epidural fat. That hole is getting bigger and it's getting easier to insert this nerve hook into the foraminal space. Okay. Just going to keep going. It's millimeters at a time, literally millimeters at a time. And really, we start to see more epidural fat come into our field of view. And I'm just going to keep fast forwarding. And pretty so one of the ways we can, when we get bleeding into our field, obviously it's very difficult to control through a small port. So one of the things, and now you start, pause for a second. I'm going to get back to what I'm saying here, but now you really, before you started to see this pulsation in there, that's the epidural fat along the dura that's pulsating with the beat of the heart. So that's a really good landmark to look at. But one of the ways, and I'm doing that here, obviously there's some bleeding in the field as the irrigation from the endoscope goes in and out of the scope and into your working space. One of the ways to control that bleeding is to put your finger on the other end of the endoscope so the water stops flowing in and out. And that actually tamponades and stops that bleeding, allowing us to see more clearly the structures and the anatomy. So I'm just going to back up a little bit and that's so I do that right there. And you see your field of view is really clearing up. In fact, you can see some dura deep in here. It just cleans up your field of view very nicely. Okay. And at this point, I'm satisfied with the decompression. I placed the nerve hook in there. So you will see me start backing out the sheath for the endoscope with the sheath. Okay. Okay. So let me close out of this, go back to the presentation. Any questions about an endoscopic foraminotomy before we go to the next procedure?
Brain turns, if y'all have any question, now is the time to put in the chat. There is a question that says, are there ever concerns of going too far when drilling?
Of course, yes, there are always concerns with going too far, which is why this procedure, although, minimally invasive, it's a great procedure. Patients do very well, but it can take sometimes a little bit of time as you're kicking up all that dust, creating a snowstorm, and you can't see. You're literally going a millimeter at a time with the drill. You don't just want to push willy-nilly until you don't have any resistance against your drill anymore. I don't know if you saw in the video, and how much time it it took, but drill just a millimeter of depth. You have to take the whole drill out, reassess your situation, make sure you can see okay, and then you keep going so that you don't plunge with the drill. It's very important.
Yes,
Good,
thank
great
you.
question.
Somebody else was asking if you could show where the spinal nerve in the endoscopic view was.
So the spinal nerve, the exiting nerve root there is actually not visualized, but it is. I can show you. So this is when the endoscope first goes in. The bevel is pointing towards the disc space. So this is all disc material. To the left of the screen is towards the patient's head. And so on the other side of the sheath is where the spinal nerve is, the exiting nerve root. So it's not something we see until we start backing out the endoscope. And I don't have that saved on the video. But great question. It's always on the other side of this sheath. So this will be the pedicle. So this was L23. This will be the pedicle of L3 going into the superior articulating process up top here. And on this side will be, next thing will be the L2 nerve root, right? The exiting nerve root, which is L2. And above that will be the L2 pedicle.
Great, thank you.
Okay.
Another person asked if you could clarify how this procedure helps relieve the pinching.
Yes. So going back to the MRI. So what if I can demonstrate on the MRI scan, this patient on the right side, their L2 nerve is here. So you guys see how open that foramen is. And here on the left side, we have some disc material and pinching of the nerve. You can't actually make out the L2 nerve on the patient's left side. So when we go in with our endoscope, we're going into this space, we're drilling out the superior articulating process, which is this of L3, which is this structure partially itself here, taking away some of the disc space and freeing up that nerve. Does that make sense?
Yes,
Okay.
perfect. Thank you so
Okay.
much.
You're
Um,
welcome.
and then the last question is if there are any cases where this procedure is insufficient. If so, what procedures would patients need as a follow-up?
But fantastic question. And the answer is yes. There are situations where there are many successes, but there are situations where it doesn't help. Very, very rarely would it make it worse. That's a complication. But sometimes, and the way I counsel patients is I tell them, look, this is a great next step. You can always go back and do the definitive big scoliosis surgery. You don't burn your bridges by trying this, but it may just give you enough relief to make your quality of life manageable and better. So you can always, if this doesn't work or if it doesn't last, you can always go back and do the bigger definitive scoliosis surgery, which is a major operation, but you can't go back and do the reverse. You can't have the major scoliosis surgery and then do this procedure. More often than not, patients elect this smaller procedure, and more often than not, they don't go on to need the big scoliosis surgery with the screws and rods and such.
Great, thank you. Actually, there is one more question that I think we have
Mhm.
time for. It's about what the recovery time is and if there's possible complications. And then
Mhm.
somebody was also asking if you had the MRI showing the post-op results.
Great questions. As far as, so this is an outpatient procedure. You go home the same day, and recovery is 2 weeks, meaning there are some restrictions. We ask patients to avoid or limit their bending, twisting. Certainly don't lift anything for 2 weeks. And that's pretty much it as far as the recovery. And then they can resume normal activities. Um, what was the follow-up to that question? MRI, post-op MRIs, I only get those if they didn't get any relief. In this particular patient, she did great, so I don't have a post-op MRI for her. But in those patients where they don't get any relief, I do get a post-op MRI to see what things look like and, have a discussion with the patient as to what we think the next best course of action would be.
Right.
Was
Thank
there
you.
another part to that question?
No, I don't believe so.
Okay,
Awesome. Thank you so much.
you're welcome. So the next procedure I am going to talk about, which is really near and dear to my heart because we've sent pilots, Navy pilots, back to full duty, and these guys do experience G forces that the rest of us don't. And so they have had studies that show that disc replacements, the actual implant holds up to these G forces and remain intact. So this is obviously fusing vertebra and pilots is a problem. By doing disc replacements, we've been able to send them back to full duty. And so this patient here is a 41-year-old security guard um, in a place where I mean, it's extremely high impact situation. He presented with a work injury with neck pain and symptoms of myelopathy. And for those of you who are not familiar with the terminology, myelopathy are a constellation of symptoms that occur when you have spinal cord compression, which is what you see here. And those symptoms are things like unsteady while walking, unsteady gait, dropping things with your hands, spastic reflexes, things like that. And what we see here, again, this is a profile view of this patient. These are the cervical vertebra squares, these are the discs in between. This patient has a disc herniation between C4 and C5, but what's most concerning is that this is his spinal cord right here, this stripe. Okay. Just for everyone's knowledge, everyone's spinal cord ends at lower thoracic, upper lumbar spine. That's normal. And below that, you have nerve roots of the cauda equina below that. So this is spinal cord, and the white is fluid that cushions your spinal cord. So there's severe spinal cord compression here. You can see on these cross sections here. And in fact, there's also what we call cord signal change on the spinal cord, which means that there's a discoloration in the spinal cord as a result of this compression, which is concerning. Going back to the x-ray, I also got a flexion extension or dynamic x-rays to demonstrate that this patient does not actually have instability between C4 and C5, because that would preclude the ability to put a disc replacement. You'd have to fuse that. So we did our due diligence. He does not have any instability. He has this spinal cord compression. So we took him to the operating room. Um, Pardon me. We took him to the operating room, and we removed the disc. And I have video, but going back to this, we removed the disc entirely and we replaced it with an artificial one. So let's go to these are the intraoperative x-rays, just to demonstrate to you us putting a trial into the C45 disc space. It also realigned him quite nicely. His curvature looks great. This is what the artificial disc looks like from the side, and this is what it looks like from the front. And on my video, you'll actually see what the implant looks like. It's kind of a ball and hinge type mechanism, which you can't see on the x-ray, and it allows for full range of motion. It does not fuse the two vertebrae together. It allows for full range of motion of your neck, both rotationally and translationally. Okay, so let me go to X out of this video and go to this one. Okay, so we have the anatomy here, and I'm going to fast forward through some of this. But what you're looking at here, this is the C4 vertebra here. This is C5 vertebra here. And we place these pins into the vertebra and provide some distractions so we can then clean out the disc space. So we use different instruments to clean out the disc space. What you're looking at here is end plate of C5, um, end plate of C4. And when you're doing these artificial discs, it's really important, not unlike a fusion, you don't want to violate those end plates. You need to have a pretty intact end plate surface to place these artificial discs. So here we are using different instruments, including a drill, a curette, to really clean out the disk space. You're going to look at that. As far as the exposure getting down to the front of the spine here, some of the anatomy, I find the neck anatomy very beautiful because it's looks like a textbook almost every time. But once you make skin incision, what you encounter first is a platysma muscle. Underneath that, you encounter the sternocleidomastoid, which runs this way. By the way, I'm on the patient's right side. Okay. Then you encounter this way, fibers going this way called the omohyoid muscle. And behind this retractor are the carotid sheath. So the carotid artery and the jugular inside the sheath. Okay. And behind this retractors are esophagus and trachea. At the end, you'll probably be able to see the anatomy a little bit better once the retractors come out. And I do apologize, I do not use a microscope for this, or I just use my loops and headlight when I do these. And so I had, in order to video this, I had an exoscope camera on top of me. So you'll see my head coming into the field every now and then. I apologize for that. But I think you're able to see the anatomy fairly clearly here. So just removing disc material with a little pituitary instrument. That's what this is called. That's suction. I'm going to fast forward. And we keep working, again, making sure we maintain the integrity of the end plates. We keep working back, removing disc material. until we encounter the posterior longitudinal ligament. Okay. Okay, I'm going to fast forward. We keep working our way down. And this gentleman oftentimes, as you oftentimes see, a posterior osteophyte or bone spur that needs to be drilled down so you can get down to the posterior longitudinal ligament. So now I'm inserting a nerve hook underneath that ligament. And more often than not, there's a really good plane between ligament and dura. So you want to find that plane, and sometimes you end up going layer by layer trying to get there. So there, that's actually, you got a glimpse of Dura just for a second there. You see that shiny down there? We can rewind a little. That shiny bluish hue that is peeking out from underneath the ligament, that's Dura. That's the plane that you want to be in, and you want to clean everything out. You kind of caught a glimpse right there. Clean everything out above it. Okay. There you kind of get a glimpse. And once you get, there it is, there it is. Once you get that plane, the instruments are slide in much easier. That's how you know you're in the right plane. You want to clean that out and then keep checking to make sure that you're decompressed. All loose disc material has been removed. There, just cleaning it out. And as a side note, while we're working on these cases, especially in cases where there's spinal cord compression, we often use, or we always use neurophysiologic monitoring. So we're monitoring the patient's arms and legs EMGs continuously throughout the case so they can alert us if there are any changes in the patient's neurologic status. And if so, we modify what we're doing. Okay, so we keep working. Gonna fast forward the decompression. And again, I apologize for my head getting into the field. Okay. Okay, a little irrigation. Okay, so this is all dura right here, all decompressed. And now we start to size up our implant. Let me rewind for a second here. Can you guys see? You should be able to see. Let me backtrack for a second. I just want to point out one thing here. If you can see this upslope, or I like to call it the smile of the level below at C5, that's called the uncovertebral process right there. And that's a great landmark that your opening or your decompression is wide enough to not only encompass the central stenosis or the compression of the spinal cord, but you want to make sure also that the nerve roots coming off the spinal cord exiting the foramen are also decompressed as well. So you don't have residual radicular pain. So that's a good landmark to have. In addition to that, when you put these artificial discs in, you really want to have good coverage of that disc space. You want to go uncus to uncus. I like to demonstrate that. And you can see on this face-on view of the final X-ray, here's our uncovertebral process on one side, and then on the other side, and we got good coverage, uncus to uncus of the implant. So you really want to try to accomplish that if you can. Okay. Okay, so here the trial is going in, or that might actually be the implant. So I did show on the PowerPoint presentation the x-ray of the trial. That's the actual implant. And I'll just show you the component of the implant. Once I take that inserter off, you will be able to see a bit better of what that looks like. There are different products out there, largely surgeon preference on what we use. I've had good successes with this particular implant, so I pretty much stick to that. I'm rewinding a little bit just to show you. There it is. There must be a way to pause this. I need to get rid of this. Oh, here we go. Okay, I'm going to pause it and show something for a second as I bring the implant in. There we go. Um, the implant consists of titanium against that goes against the end plates with these teeth. You see those teeth? You kind of missed that, but there are these teeth that go against the end plate and allow it to get anchored to the vertebra above and below. You can kind of see that peeking out from here. So there are two teeth on each end plate that the implant gets anchored to and is really solid. So the implant is in here. So this is made of titanium, and the inside part, which you'll see once the inserter comes off, is made of polyethylene. So the inserter is coming off now. We checked the x-ray, we're happy with it. The inserter is going to come off. And this is part of the inserter, it's coming off as well. I'll pause it once that comes off so you can take a look at the implant. These pins come out as well. And there it is. I'll pause it. So there you go. So this is the titanium that goes against the end plate, uncus to uncus with the teeth. Okay, with the kind of railroad type teeth against C4. This is against C5 over here with the teeth here. And here you can't really see it too well. Titanium peak in here. And it's on this side of the titanium, there's a concavity against which this sits. And you can see this convexity here against the concavity of the titanium, and there's motion along that, kind of a ball and hinge type mechanism. All right. Let's see if okay, and sometimes you kind of just want to send it back a little bit further, so you use that little tamp and mallet. And this is all done. There's a fluoroscopy or X-ray that we check continuously so that we don't push it back too far, um, rotate it. There's the final product, and that's that. Any questions about that? About cervical total disc replacement?
Yeah, brain turns, if you want to go ahead and put in your questions, that would be great. I'm gonna let Samantha take over.
So, the first question that our brain turns have for you, are there ever rejections of the artificial discs?
So I thank God have never experienced that. There are reports of patients who are allergic to titanium or any consistency of the or anything the implant is made of. I did have one patient who knew from the past that he was allergic, had to send him to an allergist to do a full panel allergy test and see what he's not allergic to, and if it was possible to, place if there's an alternative implant with that's made of things that he is not allergic to. But that was in my 15 plus year career. That was the only patient I encountered with this problem.
Oh, that's great. Someone asked, can total disc replacements be used at any level of the spine?
Yeah, so total disc replacements are FDA approved for one or two levels. It could be used in two contiguous levels, anywhere from C3-4 down to C6-7. Thoracic spine, there are no disc replacements that are available at this point. And in the lumbar spine, the disc replacements are approved for L45 and L5S1.
Okay, amazing. Thank you. Someone asked if all motion is conserved.
So there are different companies that make different products out there with different degrees of motion. This particular one is called Mobi C, which has the greatest degree of motion. So all motion is preserved with this particular disc. There are other products out there that are a little bit stiffer. And I think that my prediction is it's not part of my standard practice as of yet, but I do believe that over the coming years, we're going to find out ways to determine how much motion should we preserve or not preserve in a particular patient so that really one size does not fit all. There may be certain patients that would benefit from a different type of disc just because of the way the anatomy of their spine. So I think it will get complicated like that for good reasons. And it will also allow us to stretch our indications and limit our contraindications for artificial discs. For instance, we'll be using it in older patients with in patients that may have some instability on their flexion extension or dynamic x-rays. It may in the future allow us to use it on patients that we would typically fuse, but if we have alternatives where we can use a stiffer disc replacement, that might be an option in the future for these patients.
Great,
Again, not part of standard practice now. I'm just something I predict potentially, in the next decade.
great. Thank you.
Mhm.
Sort of going off of that, someone asked if you can adjust the mobility provided by the implant.
So once the implant is in, that's the implant that's in. You can't make any adjustments to the mobility of the implant, and it comes pre-made. So this particular implant that I use has a very high degree of freedom, but there are implants out there that offer less degrees of freedom.
Great, thank you. We have a question. Is it possible for the implant to shift away from its original location over time?
Unfortunately, yes. And what I will say that usually that happens. It's rare, but usually that happens when you've accidentally drilled too much end plate. That's one. reason why an implant may shift over time, or you didn't get enough coverage uncus to uncus, you didn't get enough anterior posterior coverage or didn't place it far back enough. It requires a lot of paying attention to details when you put this in, to make sure that it looks good at the end, it's placed well, but also stays that way.
Great, thank you.
Very rarely is it like the actual implant malfunction, but that can happen too.
Someone asked if you can use this procedure to replace a disc prolapse in the lumbar region, L4, L5, or L5S1 level.
Yes, there are artificial discs for the lumbar for L45 and L5S1,
Great.
and we go through the belly for that.
Do you think you could replace multiple discs? How many would you say is the max, and how would this
Mhm.
affect the outcome?
Yeah. So we are FDA approved for two artificial discs and two contiguous ones. That being said, there are off-label uses for three discs. There are off-label uses for two non-contiguous discs. Or, for instance, there are patients that have had a fusion at a level below and then place discs above that. And, as long as you discuss, you let the patient know that this is, yes, we can. They often come and ask for artificial disc because they don't want to be fused more. They don't want the increased uh, lack of range of motion. So as long as you have that discussion with the patient, yes, it can be done, but it is off label, and they sign consent for that. It is absolutely done. And, I will, full disclosure, I have done that myself and consented patients appropriately. And, I've actually had very good outcomes with it.
Great, thank you. Someone said you mentioned that a patient's neurological status might change during the surgery. How
Mhm.
so?
So we monitor the patient's continuous EMG activity, including somatosensory evoked potential, motor evoked potential. So sensory function, motor function, and there's a neurophysiologist in the operating room, that places needles in the patient while the patient's asleep in their arms and legs to monitor for that. And they're looking at the computer the entire time to make sure that all the firing of the signals is intact. So if they see a drop in signals or a drop in the amplitude of the signal or starting to see some EMG activity can alert us in that we're too close to a nerve, we're irritating a nerve, back away. So those are the things that we get alerted during surgery by the neurophysiologist as they're continuously looking at their computer at the signals going to arms and legs.
Great, thank you. Someone asked, is there any such method, such as machine or robots, that aid the accuracy of implants?
Yes, we do have navigation systems that allow us to accurately look at, identify anatomy. That's most helpful when we're placing hardware in from the back. From the front, it's not really that necessary because the anatomy is just so clear and defined from the front. But we do have navigation systems, we have robotics that aid in certain types of surgeries.
Great, thank you so much.
You're
I
welcome.
think that's the end of our questions. So if you have any parting words or advice for our brain turns, I'm sure they'd be very appreciative to hear it. Brain turns, if we could say thank you to Dr. Gilad for taking the time to speak with us this morning.
Thank you so much for having me. I really do appreciate this opportunity to share some of what I do. I love what I do. So, any questions at all, please, or anything you'd like to discuss, please don't hesitate to reach out to me.
Thank you so much.
All right. Thank you. I'm going to sign off now.
Have a great day.
You too.